I'm told not to use the mic on this thing. If I start to mumble, which I often do, just somebody in the back wave at me, please. Thank you all for being here. It feels like every 3 or 4 years, John gets me up on the stage. As he said, I've been at Langley Porter. This is actually my 25th year of some sort of affiliation with Langley Porter, which I came to right around a couple of weeks ago, and someone told me that made me the second longest affiliated person in child here at Langley Porter. But I'm heartened by the fact that I probably will never catch up to the longest affiliated person in child, who was John, who's been here 50 years. So I got another 25 to go. But I'm really happy to be here. Oftentimes, as John mentioned, I have been, since leaving Langley Porter, I have been at Edgewood. So I went there as associate medical director back in '99. I became medical director in 2002. And so oftentimes when I come here, I speak about Edgewood. And actually, when John asked me about speaking this year, he said, well, you want to come in and let us know what's going on at Edgewood? And I said, no. And there's lots going on, trust me. What I really want to do is come in and share with you all what's going on in the city with my other hat. And so about 2 years ago, I went half-time at Edgewood. And I became the medical director for the Transitional Youth system of care, although it wasn't quite a system of care at that time. So I became medical director for the Transitional Youth full-service partnership and intensive case management clinic. But one of the things that got me interested in doing that was the idea that San Francisco was trying to build a system of care. And we'll go into what a system of care is a little bit later. But the idea was that San Francisco was paying attention to its young adults and the folks who were in that sort of difficult transition between childhood and adulthood, and what it means to actually serve those folks as a specific population. And that's one of the things that drew me, was that the idea that this work was being done, that these two people that I brought with me we're doing that work, and we're trying to build that system. So I'm going to start, and then I'm going to have some of the state leadership team that have really been doing the sort of bulk of the work to develop the system come up and share a little bit with you about what it means to do that work. And the reason I frankly wanted to do this is because, as I said, I've been affiliated with this place for a long time, and I know we don't get a lot of this kind of stuff here. We actually don't get a lot of how do you make giant changes happen here. We get a lot, we're really good at how do you take a patient and work with them. And if we're in child, we get a lot of how do you take maybe a patient and a family and work with them. We don't get a lot of how do we do large system change. And I know as a trainee, it can sometimes feel like that stuff just magically sprouts out of the ground, or that you're mostly sort of the victims of the winds of change that happen to systems. But I wanted to sort of bring folks here who've been sort of intricately invested in changing the San Francisco system to let you know that it's possible. So for those of you sitting in trainee row over here, to know that someday you too, even as a child psychiatrist, can make real change to large systems, and they don't just have to be academic systems. That child psychiatry has the capacity in all sorts of places to make a real impact. And so I want to let me do the disclaimers here. Okay. Objectives, basically gaining understanding of the challenges facing youth and families transitioning from child serving systems to adult serving systems, gain understanding of the newly developed San Francisco Transitional Youth, i.e. TAY system of care, and gain understanding of challenges involving public mental health system change. Okay. And so the folks presenting with me here, and I'm so pleased that they were able to come today, and because it's a very busy week for us. We have a giant event happening on Friday completely by coincidence. So I'm very pleased that Marlo Simmons and Heather Weisbrod have agreed to be here with me today. I'm going to just say a couple words about each of them, and then ask them to sort of further introduce themselves to you when they come up. And so I just realized I'm timekeeping. Marlo is the Deputy Director of Behavioral Health in the department who's charged with building the case of care. And when you hear all of what she's done, you'll think that that's her only job. But it's not even close to her only job. She has an enormous job and has done the work that I've witnessed in the last 2 years with an incredible passion. And she is, last week, 2 weeks ago, Irene Sung presented and talked about compassionate leadership and bureaucracies. And what I didn't want to get lost, and one of the reasons I was glad that Irene did that, was to remember that bureaucracies are driven by people and the passion of people. And Marlo certainly has that passion. And frankly, this system of care would not have been built without Marlo's passion. And so I really am very glad that she's here. Also with me, and equally impressive, is Heather Weisbrod, who's a LCSW, who, when I started working at the TAE Full Service Partnership Clinic, was the clinic director. And Heather has a long history of working with really challenging folks and really challenging young people. And she brings a wealth of clinical knowledge and patience and experience to working with some really challenging folks. And I think, and I hope that when I say that, you would have a little bit of an understanding how it's different working with a 17.9-year-old and an 18-year-old. There's just some challenges that come along with that. So part of what I'm going to do is go over a little bit of that and give you a little bit of a developmental perspective around what that actually means. And we're not making any money on this. Okay. So why focus on TAE? As I alluded to, transitional age youth, and let me give you a definition of that, at least the one that we're using, because sometimes it varies from place, from system to system. So the age range that we're using is 16 to 24 years old. Okay. So transitional age youth, why bother? It's an enormous period of change, and it's from a developmental perspective. It's sort of, for all of you who work with people under 18, it's kind of the period that we're all trying to get them to. Right? We always think, and I know when at Edgewood, when I had kids leaving, I would sometimes say, well, good luck. Hope you do okay in your adulthood. Luckily, I've been long enough now that some of them come back, and I just had a grandma tell me the other day that the kid that I had no idea would do this is now in college doing pre-law. So I had the developmental perspective of not seeing people that I knew as young people grow up. And actually, that was one of the things that I think Heather first realized when I got to the clinic a couple of years ago. They would introduce me to this brand new patient that I had known for the last 8 years, that I had at Edgewood as a 14-year-old who is now 22. And it got to the point where Heather would just say, do you know this one? But for me, as a career, it's been incredibly fulfilling to be able to sort of have that kind of inadvertent follow-up. Now I have to remind myself that if they're coming to me at the TAE clinic, it means that they still need help, that I didn't fix them when they were 14, but it's both humbling and gratifying to be able to do that. To see the kid who, when I did see him at 14, had some behavioral problems, but didn't really see all that disturbed, now he's a full-blown schizophrenic. Or the kid who I frankly thought would be in jail by the time he was 18 and a half, making it at 20 and talking about getting a job. And so it's been an incredibly humbling experience for me as well, to be able to see that trajectory and to see that in patients' lives. When I was training here, people would talk to me about so I'm going to turn to the training road over here, about the natural course of development for child psychiatry, and how sort of as you age as a child psychiatrist, the patient population you're willing to serve ages as well. I think probably 24, 25 is going to be my upper limit. But it's true. I mean, getting on the floor with a 5-year-old does not appeal to me as much as it did when I was 20 years ago. Anyway, so why TAE? If you think about it, what happens when you turn 18? All of a sudden, you have all these new rights that you've been itching for, but you also have all these new responsibilities. And I have had more than one 19, 20-year-old in my office go, I shouldn't have to do this. You should still be taking care of me. My parents should still be taking care of me. And for a lot of those folks, it really is this rude awakening in terms of what they need to do for themselves. And especially for system-involved kids. And that's one of the folks that's one of the populations that we specifically targeted. And when I say system-involved, I mean foster care kids, or kids in the juvenile justice system, kids who are aging out of some system, some public system, that might not have family that teaches them how do you open a bank account, how do you cook for yourself. We have one young man who basically has been in some sort of residential care from age 13 to 18, almost 19 now, who just for the first time went to live in an SRO. Does everybody know what an SRO is? Single room occupancy? So for the very first time, a couple of weeks ago, went to live in an SRO. First time ever having to take care of himself in any kind of real way. He basically, the first weekend, had chips all weekend for dinner, right? So you gotta teach him how to cook. You gotta teach him all these things that families would naturally teach people. And our system, if they stay in the foster care system, tries to do some of that, but the truth is a lot of them don't want to be in that system anymore. And so what the point of contact they continue to have is the mental health system. And so our case managers wind up saying, okay, do you have clothes? Do you have food? Do you know how to cook? Okay, you're going to go live in this SRO, which is better than being in a shelter, but do you know what that means? And so helping them make some choices that you feel are wise and not completely impulsive can be a real challenge, because all of a sudden they have the legal authority to make decisions for themselves, but they may not have the emotional maturity. They might not have the financial ability. Just last night, I was in with a 18-year-old who wants to be his own payee. Does everybody know what that is? So what that means is he's on SSI, and someone else has been managing his benefits for him. His grandmother has been managing his benefits for him. And this is a kid who, frankly, spent a year in juvenile hall because the system was so worried about sending him home because of his mental health issues and they couldn't find a treatment facility. So this is a kid who I didn't have a whole lot of optimism about. So he came to see me last night. He wants to be his own payee. So we started talking about bank accounts. We started talking about how do you manage your money. We started talking about what is your rent? Like, what do you know? And that's the kind of thing that this age group has to really grapple with. And if they haven't had the family, if they don't have the support, then they don't know. And it takes, frankly, folks like us that they trust, because they're not going to go to the pediatrician and say, I need your bank account. You know, they're not going to go to somebody else and say that. They're going to come into the mental health system. On the other extreme, the folks who do have families, it can be incredibly disruptive to whatever equilibrium they've set up when the kid turns 18. When you have a child who has significant mental health problems and they turn 18 and all of a sudden they have all these rights, and you're used to dealing with a children's system that says, okay, mom or dad, you can sign them into the hospital, and then all of a sudden you can't do that. The families don't know what to do. I've had families who, and this was again a phone call just yesterday. We have a family in the day clinic who we have two of the children are in the mental health system in our clinic, and another two of the so I think all of the kids in that family have some sort of mental health issue and have been hospitalized. And so one of the kids in our clinic, the mom was on the phone with me just last night trying to figure out how do they talk to the inpatient doctor so the inpatient doctor will actually talk to the parents, they don't have to, so that they understand that this is a primary concern, what the primary concerns of the family are. That the family is willing to take the kid back, but just not the way they sent them out last week, which was barely compensated and not doing well, so they're back in the hospital. So those are some of the kind of challenges that the families go through in terms of not all of a sudden not having the power to intercede for your child. And it breaks the hearts, frankly, of many parents. and the parents don't understand, and they complain bitterly about there's nobody here to help me the way the children's system used to help me, and I don't know how to do this. And it's all understandable, right? It's all part of growing up, but it's part of growing up with a chronic mental illness and what that challenge means to both the kids and the families. And pardon me, like I said, I've been here around here way too long. I should probably be using terms like youth and young people, and occasionally my old school flips off, I call everybody kids. So, I mean, frankly, have you yelled like kids to me? Okay. Okay, I'm going to shut up because I actually wanted more hear from Marlo and Heather. Just to sort of locate the TAY system, for those of you who aren't in the room, I'm pointing to the screen. The TAY is sort of between children, youth, and families, and adults, older adults. So this is how EPH breaks down its behavioral health. And so you have the general, and you have ambulatory care, and ambulatory care you have these points of contact with behavioral health, and then specific behavioral health clinics. And this is the system, these are the different systems, right? And so that's why we're trying to build a transitional age youth system, so that we have something that will catch these young people. Levels of care, so this is where we want to keep everybody, right? It's sort of the bottom of the pyramid at wellness. You know, we want, but we recognize that there are sort of different levels that people travel through in terms of need. I've got some text associated with this. So the overarching goal of the system is to identify concerns early and maintain sort of the least restrictive part. So as you go at the base of the pyramid, it's sort of the least restrictive in terms of wellness promotion, early intervention, and then supported education and housing, vocational educational services, outpatient mental health, and then more intensive things, and then sort of residential treatment, and then crisis. So we want to keep them out of this as much as possible. But frankly, in terms of the clinic that I'm at, we get a lot of this. You know, we get a lot of folks bouncing in and out of the hospital, unfortunately, a lot of pushing in to go see the clients. So one of the things I really like about the clinic is that I can go and do home visits. As a matter of fact, I have to go do home visits because we have 4 or 5 homebound patients who won't come out and see me, right? So we have to go visit them. Okay, and so I think I've made the case for a system of care, but sort of more formally, the concerns overlap across multiple systems. So it's mental health, it's housing, it's educational. So do you want a GED? Do you want to go to college? So behavioral health is a top priority. So when you go and talk to the juvenile justice system or even the adult justice system, behavioral health is a huge thing for them. And so the system of care that tries to capture that is a top priority for all of the systems. I think actually that need and frankly that frustration was one of the things that Marlo used so brilliantly to get people to pay for things, right? So one of the things I think she's going to go over is some funding that we've done, and to understand that this isn't all coming out of one bucket. Like people always want to know how do things pay for. Staff in the system feel unequipped to address behavioral health issues, especially around young people. So if you're an adult psychiatrist and you've been working with 30 to 50-year-olds for most of your career, and an 18-year-old comes and pops down in front of you and has all of the issues with family and can I be my own payee and all of this stuff, you're not necessarily feeling really equipped to do that. For those of you who recently transitioned into child, think about your first day and how you walked out of the adult world and all of a sudden these 14-year-olds were staring at you or these 16-year-olds were staring at you and you didn't really know what to say. Well, for general psychiatrists, that is sort of their life, right? They're used to working with, especially in the public systems, chronically ill folks, and not necessarily somebody who's in the developmental stage that our folks are in. And then the last reason is the one I alluded to earlier was that we saw, frankly, Marlo saw and Heather saw in the system places and spaces where we could leverage housing funds, where we could leverage mental health funds, where we could leverage educational funds to actually get these young people the things that they need. Okay, I'm way over my time. I'm a lousy timekeeper when it's me talking. So I would like to introduce next Marlo Simmons. She's going to come and talk to us a little bit about the system that we're building.
Yes.
And tell us a little about yourself.
Okay. Hi, everybody. I'm Marlo Simmons. As Robin said, I'm the Deputy Director for Behavioral Health Services. You saw where I sit in the org chart. My background is in public health. I am not a clinician. I've done only a few years of direct service doing really community health education with young people. In that work very early on, I realized I really like thinking about systems, and especially I got to work with some really incredibly dynamic folks, and I could see how the system didn't support them. And so I really wanted to go into systems work to see how I could better support the frontline folks that were really doing the most dynamic job. And so I've been within behavioral health for about 10 years, and actually have worked on TAE for even long before that. So in 2007, Gavin Newsom put together a citywide task force to look at transitional age youth. There's been, certainly at the policy level, a realization that, and we talked about it really, really well, about how the transition from children to adulthood is really complicated. And there are many young people, especially those that have come from really difficult backgrounds, that are not making that transition successfully. And so this task force, multi-year task force, tons of city departments, and we came up with a lot of recommendations for solving all of the problems. It's 10 years later, I think, one of the 16 recommendations has been implemented. And one of the things that I'm kind of going to focus on, that every single task force committee that the city ever puts together talks about coordination and collaboration. But it's kind of, what does that actually mean? And so we're really trying to, with this work, take steps forward to, really put something behind that. Click, click. Okay, and just, this slide talks a little bit about services that we have, and showing that while we are building a transitional age youth system of care, children and the adult system already see TAE. TAE are everywhere. So we are not by any means trying to replicate or take over those services. We just want to add on an extra layer and really kind of a bridge between the services. And we've done a lot in the last couple of years that we've been working on this, but quite frankly, this is kind of where services are today. And so, again, working on the task force, the idea of coordination and collaboration was a really big deal. And there have been a lot of new resources added over the last 10 years, which is really, really exciting. There are now foster care benefits up to the age of 21. The probation department now has a special unit for transitional age youth. If you go to the homeless and supportive housing department, which now kind of operates all the housing in the city, they have specific folks that are working on youth and transitional age youth. So there are very few areas of social services that don't have TAE services, but if you look at the outcomes for the most vulnerable young people, they're not any better than they were 10, 20, 40 years ago. So we really have a lot more that we need to be doing. When we started the planning, so again, I serve as deputy director and do lots of fun things. And 2 years ago, our director said we really need to do better by TAE. Marlo, you have a background in TAE, see what you can do. And so what we're talking about is really the work that a whole team of people have done over the last couple of years. So we built on previous planning. We did a lot of conversations with people, frontline providers, system providers, city departments. We did surveys, did data, kind of really took a step back and said, where are the gaps and how can we be doing better? And we have 3 primary goals that we have for the system. One is that we want to do better for TAE, obviously, and give them better services that really meet their needs. We want to provide support for the providers that are doing the work. And so there is never enough support and training and opportunities to network that we can do for providers. And then the systems piece, and this is really like the really tricky piece, because what does that actually mean? And it's the coordination across systems. People that kind of are aware of, the work that the department's doing around EPIC, which is probably the most ginormous, like, public sector thing that's happened in San Francisco around electronic records. None of that work is easy. And our system, which is good, and I want to just appreciate all of you that are doing clinical work and frontline work, but our system tends to really focus on we need more folks doing frontline work, and if there are budget cuts, it generally comes through the administration, and so the amount of time it takes to build these systems requires resources that aren't at the front line. And one of the things that's been really exciting about the team that we've built to do the TAE work is that they're folks that have decades and decades, collectively, not just Robin, of work doing frontline work, and those are the folks that need to be in the position. So those of you who might think of having an interest in coming into administration, it's really exciting. And so the frontline work that you're doing now can be transformative, because I'm not a clinician. And so there's so many things, shortcomings that I have, that we've built a team that really supports the mission that we have. This is a quote that I use pretty much on every single PowerPoint. It's about a young person and their experience of, as my life got bigger, my illness got smaller. And this really, I'm hoping that many people know about the concepts of wellness and recovery. And it's not just, in mental health and substance use, it's not just treating the symptoms and making the symptoms better, but especially for young people, it's about helping them build the life that they want. And this is where you're talking about the family engagement is really important, helping people to get jobs, get the benefits, figure out how to eat. And that's something that takes individual clinicians need a whole team and a whole set of systems to help them do that. And so this is, an example of where in San Francisco, we have, just within DPH, the level of silos is, pretty extensive. And then you start talking about the foster care system, the criminal justice system, the homeless serving. So there are a lot of people that are engaging with young people that need the support services that we should be providing. And so the goal about trying to coordinate all of this and be sure that all of the clinicians and frontline workers that are in these systems have basic, how do you identify a young person who needs help? So I have a young person I really, really care about, but I don't know how to get them access to the services that they need. How do I do that? Mental health first aid, motivational interviewing. When we talk about the system of care, if you are in San Francisco working with a young person who needs behavioral health supports, you are part of our system of care. So all of you who interact with young people are part of the system of care. And so eventually we want to have, kind of across all of these systems, shared language, shared knowledge, and then the relationships. We are taking, we didn't intend to, but the more we kind of get into our work, the more we realize that we're doing really a collective impact approach, and this could be probably a 3-day workshop and conference about collective impact. And I'm sure many people have heard of this, but it's really the idea that that we want to have for all of the resources that are available around a shared issue. For example, all of those TAE specific services that I talked about that the city's funding, they're all doing individual impact and really great things, but how can we bring all of those people together to move in the same direction? And so Heather's going to come up and talk a little bit about specific programs and some of the things we're rolling out. But I just wanted to talk about this common agenda, that if you sit down with any of the folks that are in that slide a minute ago and talk to them, we all have the same goals. We may have different mandates, different young people we're working with, but the intentions of our work is really very similar. And what we found is it's really about building relationships across the system. For frontline providers, they need to be in a room together and really talk about the challenges. They need to understand about the services each other provide, so they'll make referrals. Having a sheet of paper with a list of places you can send someone, if you really care about that young person, you're not just going to send them to random places on a piece of paper. You want to know where you're sending them. Can you trust those other providers? And so a lot of the work we're doing is really convening people and giving space for them to build relationships, which is this big event we have on Friday. It's our 200 closest friends that have been involved in many, many of these meetings coming together for the first time, like a family reunion. And that the relationships also go to the systems level, the funders level. And one of the things we did is there's lots of city departments that have a lot of money that are concerned about TAE. So So we spent about a year working on relationships with them, and this goes to the funding point. This was our budget last year for all TAY services. When we got started, we were able to go to all of our partners in behavioral services, let them know what we were doing, and we were able to combine all of the funding together into one pot. So going back to that collective impact model, where we had lots of random things happening, we now have one funding pot that we're using very intentionally. And so this represents our budget this year, which is very exciting. And really what this shows is that there are a lot of people in the city, especially city departments, that have money that want to invest in helping young people get the supports that they need. And so we've increased Medi-Cal revenue, we've got new SAMHSA grants, we've got new funding from substance use services. And again, all of this is integrated. We have crisis support funding, Department of Children, Youth and Families, and the homeless and supportive housing departments have also invested funds. And so this is really moving us towards that collective impact. And of course, my fantasy is that every year this growth will be the same or even more. And we will have more and more of the funders in the city understand what we're trying to do because they've been part of it, because we have those relationships. So these are our funding partners as of this moment. We're working with one more that we hope will come on board soon. And obviously I'm not going to go through these, but a lot of these are organizations that I'm assuming many of you recognize. And the idea of each one of these organizations, like for transitional age youth at least, moving in the same direction, and as they get money, they are investing that. As they get staff, they're investing in the mission that we have. And so we have spent hundreds, 1,000 meetings building the relationships with these people. And multiple of our partners are now going and seeking grants, calling us to the table to try and work together so that what they're doing is aligned with what we have. And Heather's going to talk a lot about what these folks are actually doing. And I think we'll have time for questions at the end. And, yeah. Okay. So next.
Hi everyone. I'm Heather Weisbrod, and I am in the transition from clinic director, the Transitional Age Youth Full Service Partnership Intensive Case Management Program, and into administration with this new day system of care, behavioral health. And I have had the opportunity over the past 15 years or so to work in many of the silos that Marlo showed us in San Francisco, including homeless services, primary care, the children's system in mental health, and the adult system in mental health, and now in TAY, behavioral health services. The silos are real. And one of the things that has been nice about this kind of slightly more bird's eye view that I have now and I'm getting more of is getting to see all the places where these services and programs interact or have the opportunity to intersect and collaborate further. So I'm going to go back a little bit and back to the needs assessment that we did and talk a little bit about the program level findings and what we decided to implement in terms of services and programs. So what we found, I guess first of all, is that we had some services already in place that were case specific. There was a full service partnerships and the prevention and recovery and early psychosis, which is the early intervention for youth psychosis. And those have been in place for some time. And we found that they were effective, which we're very happy to see. They reduced hospitalizations, emergency room visits, and increased residential stability and employment. And however, they were two kind of very small programs and only serving a very particular level of youth. So going back to that pyramid that Robin showed us earlier, they're kind of at that upper level of the pyramid. So there are all of these TAY who were not being served through those programs. We also found, in terms of service gaps, that outpatient, we heard over and over and over again from all of our partners that outpatient services were very, very difficult to find and to access. And that if TAY were finding outpatient services, they weren't engaged. Often within behavioral health services, the outpatient services were living at the adult level, and so meant TAY having to navigate an adult clinic, large, kind of intimidating, not geared for TAY. Also, substance use services were a large gap, and mental health provider capacity to support mental health or substance use treatment, provide substance use treatment was also a gap. Crisis response was a huge gap. We heard that over and over again, and especially from some of our homeless and housing service providers. Residential treatment, also a gap. And then a lot in terms of housing, that there weren't enough housing programs with adequate supports for youth with serious mental illness, for homeless stay who are transitioning out of higher levels of care like the hospital or from residential treatment, and I mean in general, San Francisco, housing is generally a gap. We also have figured out through that our priority populations we really needed to focus on were TAY with severe mental illness and substance misuse, TAY involved in or aging out of kind of larger systems, foster care system, juvenile justice system, special education. And then there were specific populations that were being underserved, so African American youth, Latino and Mayan youth, Asian and Pacific Islander youth, and LGBTQ youth. And then the other large priority population were experiencing homelessness or at risk of homelessness. We also, this probably seems obvious, but additional findings were that access issues made it difficult to find services and to stay in services. So they included stigma, knowledge, the actual access requirements for getting into outpatient care, having to go in for an intake, schedule an intake, go in for an intake, sit through a long intake assessment, show up for a follow-up appointment. And that's some of the outpatient clinics, that's one of the lower threshold and requirements, or even higher requirements for some of the adult outpatient clinics. And so we started really thinking kind of early on about trying to implement some solutions rather than waiting until this whole needs assessment was over. So some of the things we started thinking about were linkage support and low threshold services with providers reflective of the population served, and having more handoffs and peer staff to help with engagement and help with supporting across systems. And then we found over and over again also that youth get lost in transition between systems and between levels of care. So if they're transitioning between the children's system, the adult system, transitioning from juvenile justice or foster care out of those systems, if they're transitioning from a higher level of care to a lower level of care, there's a huge risk of just falling through the cracks and not making it to the other side. And so one of the things that we've started talking about really early on, and we're talking about continuously and developing multiple strategies for, is how to hold TAY as a system within and having a well-coordinated response and ability to link TAY. So these are some of our TAY-specific programs that we are funding. The ones in purple are the programs that are new. The TAY Linkage Collaborative is on the newer end, and we actually established that very early on in the process because it was very clear from the beginning that we needed to help fill in some gaps and help TAY get into care in the services that existed. So I'll talk about that, TAY Linkage Collaborative, a little bit more. We have our full service partnership programs, which we're continuing to fund. They've been going on for a while. The early psychosis intervention program we're also continuing to fund. And now we're doing funding some TAY population-specific and engagement and treatment programs that are designed to be very low threshold mental health programs that make it easy for youth to access, engage. We don't have a lot of requirements up front for getting services. And that also are really focused on providing culturally appropriate and responsive services. So they're programs and agencies that are really embedded in the communities that they serve. We have some TAY homeless treatment team programs, 2 programs that will be serving TAY who are homeless, living in shelters, or living in transitional housing programs or permanent supported housing. We have wanted to develop some leadership programs for TAY. So we have a certificate program and an internship program for TAY to get experience in the behavioral health system. So the idea is creating opportunities for leadership, but also a pipeline for TAY to get into the behavioral health system. And then we wanted to create opportunities for TAY providers themselves to be well trained, to get support, and to have kind of a shared means of providing services today. And so we created this network development training capacity building, and it's really multi-tiered. So we have a 2-year clinical track for clinicians, and then kind of an overall set of trainings that we'll be providing to all levels of, and all different types of people working with TAE, in order to make sure that they are well versed in behavioral health. And in development, we have a new crisis program, which we're very excited about, residential treatment, and the Community Mental Health Academy is for non-clinical providers, so we'll give them some kind of mental health 101 training. And then we're strengthening our network of TAE point people, which is something that's been around for a long time. Behavioral Health Services has had TAE point people in the adult outpatient clinics, and it's been not very well utilized, and so we're going to be reinvesting in that and really strengthening that network.
There.
So this is back to the pyramid. We wanted to make sure that our services were at all levels. So we have our triage and crisis support, our homeless treatment team, or not actually, but our residential treatment, which is new, very much in development. The TAE FSPs and early psychosis, our TAE engagement and treatment programs with a lower threshold, and then TAE leadership programs. And then here we have the Linkage Collaborative, which goes across all of the systems. So the TAE Linkage Collaborative is, the TAE Linkage program itself was started in January of 2017, early on in the process. And it has been, it was immediately really well utilized. We started getting referrals in the first week of being open. And I think we served upwards of 200 or well over in the first year. And so the TAE Linkage program was really established to help TAE get into care. So get a referral, figure out what the young person needed, and figure out where they could go, do whatever needed to get done in order to support them linking to care. So whether that was just finding the place, doing a warm handoff, taking them to intake times, or whether it was even providing some case management, care coordination for a short period of time to make sure that they had what they needed in order to be able to stay firmly engaged in behavioral health services. So the TAE Linkage Collaborative, as we're calling it now, is an expansion of that TAE Linkage program pilot. It's now a partnership between DPH, between RAMS, which provides peer support services to the linkage programs, Felton, which provides substance use linkage services, and then Progress Foundation, which is coming on, and they'll be providing kind of linkage and following TAE across linkage to residential treatment and following TAE through their time in residential treatment. So the goal is to help TAE find and access behavioral health services at all levels. It provides consultation to providers, so we field questions all the time, information and referral, some short-term care coordination, and then some peer support. And we're starting just now to look at outcomes. We're doing an evaluation of TAE served, where they've been linked, how secure the linkage was, providers' experiences of the Linkage Collaborative, TAE's experiences of linkage services. So we're excited to see what that yields for us. And this is just a visual of all of the different services and systems serving TAE and referring, linkage being the door. It's not the only door, we always say, but it's one door. And linkage providing help with accessing all these levels of care.
Yeah.
This is our system.
Yes, this is our new kind of vision of the year. And a lot of stuff we've already talked about, and I won't go into lots of detail. But really it's, you can see the forest here, the children's system and the adult system, which are existing and have like some good growth going on. And the TAE system of care is really trying to bridge. And we have, our whole range of services from intensive to helping young people get jobs and develop leadership skills, crisis supports down here. The homeless treatment pilot, we are actually getting a van and building it out as a mobile treatment room, and that's very exciting. Some private funding coming in to help us do that. And then again, kind of the resources raining down on the whole system, Linkage Collaborative for all of the different services. So I could spend 3 hours on this, but that's just kind of a bright and happy vision that we have that we're all working on. So yeah, so we are happy to answer questions if we have a few minutes to do so.
I guess my question would be, you sort of talked a little bit briefly about different minority groups that are underrepresented currently by CARE. Can you sort of touch upon what you guys are exactly doing and how you're sort of catching them before they fall through the net?
So one of the main things, and I mean this is something that's going to be, there's no easy answer to that, right? But one of the things that we're building is this low threshold set of programs. So again, they are organizations, some of them even aren't mental health providers. They are really organizations that have a lot of trust in the community, young people engage. Maybe they're places people are going for drumming or beating or, a DJ program. And by having mental health providers embedded in those programs and expanding their capacity to train staff, to provide services on site, and to not require Medi-Cal billing or any kind of the hoops and some of the barriers that young people face. And the providers are predominantly, I don't want to say all, but mostly are people actually that have come from the community. And again, these are really culturally rich organizations. And so it's something we've done with Mental Health Services Act funds with other populations. Over the last 10 years, it's been really successful, so we're expanding it here. And so the idea is that a young person, and it may take 6-8 months to engage them, maybe they're part of a drumming circle, and the therapist can be integrated into that. And the idea is that if you build trust, help them develop relationships, and then as you identify those that really have more acute needs, they'll trust you, kind of flow them in. So that's one strategy, and then of course all of the training that we're doing at all the different levels we're being very mindful about how do we integrate, not just it's Tuesday, let's have a cultural competence training, but how does every single thing that we're doing integrate culture and trauma and a lot of the different principles that we're really promoting.
Seeing more engagement from these communities being more incorporated into the system that you guys sort of created. So
we are
sort of in development.
We are beginning that, and so we're very hopeful. And so, do you guys have other things you would add about the culture piece?
Just that, that was one of the first things we talked about when I got there 2 years ago, was how do we get these young people who feel very much marginalized by our larger system and who will tell you they're scared to go sit in the clinic. How do we get them to even start thinking about accessing mental health services that they need? And so when you were just talking about, I was just thinking, I just got a call last week from an organization that helps kids rebuild old cars. And because I knew one of the people there, she called me up and said, we have somebody who really needs help. How do I get them to help? And so I gave them the information on how to get a linkage program. But that's the idea, that we're out there building this network of people who care about young people and helping them make that transition.
Hi, I'm Lauren Schumacher, one of the Child Fellows here in Psychiatry. Really interesting talk, and definitely, right now I'm very much on one of the frontline providers, but I was interested to hear you kind of talking more about the systems perspective, and you can definitely, I feel like you can feel how that impacts us and our patients, but often I don't know much about it, don't really understand it, don't know when things are not working, what to do about that. So I'd love to hear if you have suggestions of ways to get more involved with that and also just get more educated about thinking in those ways about that.
Oh, you want me to?
I have ideas, but
It's a great question, Lauren. I mean, the way I did it was I took a job at DPH, so that's one way you could think about doing it. And I read someone sitting in the back and she was happy to talk to you. If you want to take a job at DPH. But also I think one of the other things that I recently did was again, thanks to Irene, actually, I'm thinking about it. I went to the CMA, local CMA Royal Award. So one of the things that it reminded me was that I haven't done it lately, but when I was early in my career, I got very involved with organized psychiatry. So that's another way of looking at, of sort of getting with people and creating system change. So you can do, you can directly go into the system, or you can look at it from an organizational structure of organized professionals that then inform the system. So those are ways that I would think about doing that. So, for example, the local child psychiatry organization has a lobbyist in Sacramento. And so for a few years, I was on a monthly call, sort of figuring out the lobbyist plans for that organization. So those are ways that if you're thinking, I want to do more, you just see patients, those are ways. So you either go work in the system, which I recommend, or you do organized psychiatry, or you do both.
And right now, the TAY point people that Heather talked about, there's really folks that are interested in TAY, that are coming from all over the system, TAY specific or not, that are going to be convened. There's networking, educational opportunities about everything from like policy issues down to like clinical skills. And so if you want to reach out to us, we'd love to include you in that. And I really can't, the system, it's a tough system to work in, our system. And even on top of the work, there's some challenges. But one of the things that Irene has done in her leadership is to really carve out time for psychiatrists especially to do things other than clinical care. And so there is this opportunity to do really important, needed clinical care and then work on initiatives and kind of things that are like really kind of spark you and get you up in the morning. And so that's exciting. So I would encourage everyone to kind of think of DPH as a landing place where there could really be opportunities to impact the system.
And I just want to point out that the Langley Porter TAY point person.
Oh.
English is a TAY point person.
Are these programs, which seem wonderful by the way, that your person is organizing them in this way, are these programs for people who are private mental health? Do you know of programs similar to this
And so there are, most of the services in our system are really for those folks that have medical or are uninsured. However, the low threshold programs, for example, because we want to help anybody get access, those are not limited to folks that are uninsured or Medi-Cal. The PrEP program, which is the early psychosis program, and they're expanding to include bipolar work as well. That program, because we know the impact, like if you don't intervene as early as possible, that person's going to become our most expensive adult, utilizer down the road. And so we try very much for people who have private coverage to get them to those providers. But the early psychosis and bipolar program especially is something we've kind of been flexible about that. And then kind of across the board in the linkage program, we have folks coming in and really try to find what's needed and not just, you got insurance, sorry, slam the door and deal with it on your own.
Do we have some idea about the number of the youth that are in, well, I guess my question is, most counties have about 25% of the county population is 18 or under. San Francisco is the most unique county in California. It has approximately 13% of people who are younger. And now, in the last 10 years, we've had an increase of 100,000 people who are mostly college graduate tech workers.
Yes.
Who are making $150,000 a year or more, plus stock options, and so they're not interested in children and youth and things of this sort. What's the size of the number of kids at risk, and what percentage of that do you really have access to?
We have a few thousand young people in that age range that we serve as a system every year. The overlap with that population with the, if you look at the jail population, 20% are our target population. obviously, from our foster care. The overlap is huge.
Right.
So what, there's probably about 80, not counting the tech boom, but, about 8,000 people in that. And if you start looking at who are the ones that are most vulnerable, it's really like 5,000 to 8,000. And if you really start, that's 5,000. And so when we think about our system, we have about 5,000 people we need to get connected. And that's like a lot of resources, more than anywhere on the planet. So if we can get things coordinated, I'd say our target is about 5,000. But then you need to really estimate the population is much smaller, so surely easily 5,000.
I think collecting that kind of data is going to be very helpful in your fundraising and in your public interest.
Yes. And certainly looking at the cost
That's
of that,
exactly.
population if we don't do this now.
Exactly. Okay, good wishes.
Thank you very
Thank you all.
much.